All right, in today's Clinical Explainer, we're diving into a challenge that I know many of us face in practice: managing chronic pain during pregnancy. It's this constant balancing act. We're trying to ensure the mother's well being while, of course, safeguarding the fetus. So let's break down how to navigate this incredibly complex area.
So, here's our game plan for today. We're going to start by really sizing up the problem. Then we'll dissect that core dilemma that we all face as clinicians. From there, we'll review both our pharmacological and non-pharma options, and we'll wrap it all up by consolidating everything into some key actionable principles. Sound good? Let's get started. So, first things first, what's the true scope of this issue? How many of our pregnant patients are actually dealing with chronic pain on a daily basis? I think the answer might actually surprise you. The data shows that up to 28% of pregnant women are living with a pre-existing chronic pain condition. Just think about that for a second. That's more than 1 in 4 of the patients walking into our clinics. This really underscores why mastering this topic is just so essential for anyone in perinatal care. Now, just to make sure we're all on the same page, we'll be using the formal IASP definition of chronic pain. And remember, this isn't just acute pain that's lasted a long time. We're talking about pain that persists or keeps coming back for more than 3 months. It's this complex condition where the nervous system itself can actually change, involving biology, psychology, the whole shebang. And that high prevalence brings us right to the heart of the matter, doesn't it? It brings us to the clinician's central dilemma. We're constantly trying to navigate this incredibly difficult balance between the mother's health and the potential risks to her developing baby. And this slide really illustrates the clinical tightrope we're walking every single day. On one side, if we leave the pain untreated, we're looking at profound risks for the mother. We're talking anxiety, depression, and even those neuroplastic changes that can make the pain worse. But on the other side, well, the potential harms of medication are just as serious. Every single decision we make is rooted right here in this delicate risk-benefit analysis. So keeping that dilemma squarely in our minds, let's turn to our pharmacological toolkit. We're going to do a quick high-yield review of the main drug classes that we are most likely to consider in our practice. Okay, first up, NSAIDs. The crucial point here really is that timing is everything. There's a possible association with cardiac anomalies in the first trimester that we need to be aware of. But the major contraindication, the big red flag, is after 28 weeks. That's because of the well-established risk of premature closure of the ductus arteriosus. For breastfeeding, ibuprofen and diclofenac are generally our preferred agents. Next up, opioids. The headline risk here, and it's a big one, is neonatal abstinence syndrome, or NAS. We see it in a huge percentage of exposed newborns. Using opioids near delivery also carries a significant risk of neonatal respiratory depression. And here's a crucial point for postnatal care. Please avoid codeine during breastfeeding. The risk for what we call ultra-rapid metabolizers can lead to dangerously high levels in breast milk. Dihydrocodeine is a much safer alternative. Now let's turn to antidepressants, which, as you know, are often used for neuropathic pain. There are 2 key risks I want to highlight here. First, with use late in pregnancy, there's about a 30% risk of neonatal adaptation syndrome. And second, and this is a really important clinical point, serotoninergic drugs increase the risk of postpartum hemorrhage. This makes recommending active management of the 3rd stage of labor a very prudent move for these patients. And finally, let's take a quick look at the gabapentinoids. The key takeaway here is that the evidence is, well, it's limited. While some studies hint at possible associations with adverse outcomes, the data just isn't that robust yet. This uncertainty really underscores the need for caution, for really individualized risk-benefit discussions, and for management under specialist supervision. Okay, now we move to what I consider to be an absolutely crucial part of management. Non-pharmacological interventions are not an add-on. They are truly the foundation of chronic pain care in pregnancy. We should be using them as a first-line treatment or as key adjuncts to keep any medication doses as low as humanly possible. So one of our heavy hitters here is, of course, cognitive behavioral therapy, or CBT. As you can see, it targets that vicious cycle where these negative thoughts about pain, this will never end, fuel distressing emotions like fear, which then drive unhelpful behaviors, like avoiding activity. By intervening at each of these steps, we can help patients fundamentally change their entire relationship with pain. Now, acceptance and commitment therapy, or ACT, offers a different but really complementary approach. The goal here isn't so much about getting rid of the pain, but more about increasing psychological flexibility.
The focus shifts from this constant struggle against pain to living a meaningful, value-driven life with the pain. And for many patients, this can be a really profound and empowering paradigm shift. Okay, so we've looked at the problem, the dilemma, the drugs, the therapies. How do we pull all of this together into a practical management strategy? This final section is all about synthesizing everything we've talked about into clear, actionable principles for your clinical practice. So, here are the key takeaways. First and foremost, a multidisciplinary approach is absolutely essential. Always prioritize non-pharmacological strategies. Every single risk-benefit analysis has to be individualized to that patient in front of you. Preconception counseling is the ideal whenever we can get it. We need to anticipate higher analgesic needs around delivery, and the old mantra holds true. Lowest effective dose, shortest possible time. And finally, please bring in your anesthetic and neonatal colleagues early. Safe planning makes all the difference. And this brings us to one final and frankly critical question. Our evidence base is often pretty limited by the ethical challenges of conducting trials in pregnancy. So the question for all of us to consider is this: how do we move forward? How can we collaboratively and ethically build the robust evidence that we so desperately need to navigate these incredibly complex and important clinical decisions in the future?